Hi, colleagues in Brazil. I'm Dr. Roberto Giraldes, Editor-in-Chief of Cardiosource in Português, and I have an enormous pleasure to be joined by Dr. Keith Fox, who is Chief of Cardiology at University of Edinburgh. And Dr. Fox is going to comment on two major studies that were presented this morning at the American Heart Association 2011. Dr. Keith Fox, I want to talk about the ATLAS study and the TRACER study. They were all about therapies post-ACS, one with a new antiplatelet agent, vorapaxar, and the other one with a new anticoagulant agent, anti-10A agent, rivaroxaban. We still have a very high residual risk after an acute coronary syndrome. There's something that should be done with those patients. And the results were entirely different, opposite results in terms that patients treated with a third antiplatelet agent didn't derive any benefit from therapy, whereas patients treated with an anticoagulant, rivaroxaban, had benefit decreased event rates. So what can you tell us about that? Where are we headed in this kind of patients?
Okay, so I think the first issue is the residual risk. And large-scale prospective registry studies like the GRACE program, where a lot of colleagues in Brazil and elsewhere contributed, have shown the continuing event rate after the acute phase. And what I presented this morning was evidence that 83% of the cardiovascular deaths in the first 5 years after non-ST elevation ACS happen after the hospital phase. And that's despite the current standard of secondary prevention. So there is continuing event rates over time. And both TRACER and ATLAS have tried to address this in different ways. In the TRACER study, the vorapaxar was aimed at the thrombin mediated platelet receptor. So as you say, it's a different kind of platelet receptor antagonist on top of dual antiplatelet therapy. So on the one hand, we've got a different mechanism. On the second issue is the issue of the dose and whether this dose is right. I personally don't think that this is the end of the PAR1 antagonists, because I think maybe the dose was too high for the setting in terms of this post-ACS population. Whereas in ATLAS, a very large-scale phase 2 trial was conducted of more than 1,600 people to try and sort out the dose. And actually, it's the very lowest dose combined with dual antiplatelets that has done best in terms of this balance of efficacy and safety.
Do you think that maybe we've gone too far in terms of anticoagulant therapy and now we're going back in terms that other drugs like fondaparinux and bivalirudin that cause less bleeding might be more beneficial than other drugs like enoxaparin?
Too far, I disagree. You know, you've just seen presented this morning a study that has gone further. It has tested an anticoagulant against placebo in this population. So too far, no. But getting the dose right, yes. Because I think that there's evidence that perhaps some of the doses that were used in the past that caused bleeding may have offset benefit. So if we go back to the APPRAISE-2 trial with apixaban, that used the full atrial fibrillation dose, and there was no evidence of benefit but excess bleeding risk. Why is that? Probably some of the people who had bleeding had adverse outcome events and stopped the other therapies. So I think that's part of the mechanism, and it comes back to the critical question of getting the dose absolutely right to minimize bleeding risk but have the benefit.
So it's time to look back at the second phase trials instead of phase 3 trials?
Well, there's no shortcut to being thorough in designing the trial and getting the dose right at the very beginning.
Thank you very much, Dr. Fox. I hope to have you here again in the future.
Thank you very much. Delighted.
Thank you.